How do you modify your physical assessment technique and communication when transitioning from a 6-month-old infant to a 4-year-old toddler?
Transitioning from a 6-month-old to a 4-year-old requires a complete shift in developmental strategy. When assessing a 6-month-old, my priority is maintaining safety and comfort through proximity to the caregiver. I perform the most invasive parts, like checking the ears or mouth, last, while keeping the infant in the parent's arms to minimize distress. I rely on tactile soothing and talking in a soft, rhythmic voice, as infants respond primarily to tone and security. For a 4-year-old, the approach becomes far more interactive. At this age, children are developing autonomy and imagination. I shift my communication to use simple, honest, and concrete language, and I always involve them in the process to reduce their anxiety. For example, I might let them hold my stethoscope or listen to their own heartbeat first. I frame the assessment as a game, asking them to blow out the candles when I need them to take deep breaths for auscultation. By giving them choices, such as whether to sit on the chair or the bed, I empower them. This use of play and choice builds trust, turning a potentially frightening experience into a cooperative, successful assessment.
Can you walk us through your process for verifying weight-based medication dosages and how you handle a scenario where a provider's order exceeds the standard pediatric safe range?
My process for verifying weight-based medication begins with a strict adherence to the double-check protocol, regardless of how busy the unit is. First, I confirm the child's most current, accurate weight in kilograms. I then independently calculate the dose based on the standard mg/kg guidelines provided in our clinical decision support system or hospital formulary. I compare my calculation against the physician's order, paying close attention to the concentration of the medication and the frequency of administration. I never rely on memory alone. I always cross-reference the dose against reliable, updated resources. If I discover that a provider's order exceeds the standard safe range, I immediately prioritize patient safety by withholding the medication. I do not guess the intent or assume it is a minor error. My next step is to approach the prescribing provider directly, but professionally. I might say, I am concerned about this dosage as it appears to be higher than the standard therapeutic range for the patient's weight. Could we please review this together? By presenting the data objectively, I allow the provider to clarify if there is a specific clinical reason for the higher dose or if a correction is needed. If the order remains unchanged and I still have safety concerns, I would escalate the issue to the charge nurse or pharmacy to ensure a consensus is reached before any administration occurs. Documentation of this communication is always thorough, ensuring that the safety process is transparent and accountable.
What specific validated pain scales, such as FLAC or FACES, do you utilize for preverbal or nonverbal pediatric patients? And how do you differentiate between physiological pain and general emotional distress?
For preverbal or nonverbal pediatric patients, I rely on the FLAC scale, face, legs, activity, cry, and consolability, because it provides an objective, observational framework for assessment. For toddlers who have begun to develop some verbal skills but cannot quantify intensity, I use the Wong-Baker FACES scale, allowing them to point to the expression that matches their feelings. These tools are essential because they turn subjective observation into a measurable score, which I then document consistently to track trends in the child's comfort level. Differentiating between physiological pain and emotional distress is a critical clinical skill that requires careful observation. When a child is experiencing pain, I look for specific physiological indicators: heart rate elevation, blood pressure changes, guarding of a specific area, or diaphoresis. Pain-driven distress is often harder to console and tends to be localized. If I provide a physical intervention, such as repositioning or addressing a tight dressing, a pain-related cry typically subsides. In contrast, emotional distress is often triggered by separation anxiety or the unfamiliar environment of the hospital. This type of distress is usually alleviated by parental presence, distraction, or a comforting object. By assessing whether the child can be calmed by their caregiver and if their vital signs remain stable, I can accurately distinguish the source of their agitation and provide the appropriate intervention.
With the evolving pediatric vaccine and immunization landscape, including updated monoclonal antibody therapies like nirsevimab for RSV, how do you address parental hesitancy while staying grounded in evidence-based guidelines?
Addressing parental hesitancy regarding immunizations and newer therapies like nirsevimab requires a foundation of empathy, active listening, and evidence-based guidance. My approach is to first create a non-confrontational space where parents feel safe voicing their concerns. I use motivational interviewing techniques, asking open-ended questions to understand their specific fears, whether it is about side effects, the novelty of monoclonal antibodies, or misinformation they have encountered online. By validating their desire to protect their child, I build a partnership rather than an adversarial dynamic. When discussing RSV prevention, I clarify the distinction between vaccines and monoclonal antibodies. I explain that nirsevimab provides immediate, passive immunity, which is highly effective at preventing severe lower respiratory tract disease, especially for infants entering their first RSV season. I frame this information using a presumptive approach, stating clearly that their child is due for this protection, while remaining open to pausing and addressing any specific questions they may have. I use tools like the truth sandwich to correct misconceptions. I start with the shared goal of child safety, address the myth or concern with factual evidence, and end by reinforcing the protective benefits of the recommended intervention. I always have reliable, updated resources, such as official vaccine information statements, VS, or institutional fact sheets, on hand to review together. If a parent remains hesitant, I do not dismiss them. I leave the door open for further conversation at future visits, ensuring they know I am their partner in navigating their child's health.
How do you calculate hourly pediatric maintenance fluid requirements using the Holiday-Seeger method? And what early clinical signs indicate a child is shifting from compensated to decompensated dehydration?
To calculate hourly maintenance fluids using the Holiday-Seeger method, I follow the 100 to 50 to 20 rule based on the child's weight in kilograms. For the first 10 kilograms, I allot 100 milliliters per kilogram per day. For the next 10 kilograms, 11 to 20 kilograms, I add 50 milliliters per kilogram per day. For every kilogram over 20 kilograms, I add 20 milliliters per kilogram per day. To determine the hourly rate, I divide the total daily volume by 24. For example, a 12 kilograms child requires 1,000 milliliters for the first 10 kilograms plus 100 milliliters for the remaining 2 kilograms, totaling 1,100 milliliters per day, which is approximately 46 milliliters per hour. I always cross-check this against clinical weight trends and electrolytes to ensure the rate remains appropriate for the child's metabolic needs. Recognizing the shift from compensated to decompensated dehydration is vital for preventing shock. In compensated dehydration, the child maintains perfusion through increased heart rate and peripheral vasoconstriction, though they may show signs like dry mucous membranes or decreased urine output. The shift to decompensated dehydration is signaled by the failure of these compensatory mechanisms. I look for clinical red flags, significant tachycardia progressing to bradycardia, narrowing pulse pressure, delayed capillary refill beyond 3 seconds, cool or mottled extremities, and a drop in blood pressure. Most concerning is an altered level of consciousness or lethargy, as this suggests the body can no longer sustain end-organ perfusion. Immediate intervention is required at this stage to prevent progression to cardiovascular collapse.
You're caring for an 18-month-old admitted with bronchiolitis. During your rounds, you note new intercostal retractions, nasal flaring, and a respiratory rate of 62. What are your immediate step-by-step interventions?
My immediate priority is to stabilize the child's respiratory status, while simultaneously alerting the care team to the clinical deterioration. First, I place the child in a position of comfort, usually a slightly upright position, to optimize lung expansion. I immediately call for assistance, utilizing the hospital's emergency call system if necessary, and ensure the physician and respiratory therapist are notified of the change in status. While waiting for the team, I initiate continuous pulse oximetry and cardiac monitoring to track trends in oxygen saturation and heart rate. Second, I assess the airway for patency, and, if secretions are visible and causing obstruction, I perform gentle bulb suctioning to clear the nasal passages. This is crucial for an 18-month-old, as they are often obligate nasal breathers. After clearing the airway, I start supplemental oxygen as ordered or per unit protocol to maintain target saturations. Finally, I conduct a focused respiratory assessment, noting the depth and symmetry of chest rise, and listen for adventitious sounds like wheezing or crackles. I document these findings in real time, providing an SBER handover to the incoming team. Situation: respiratory distress. Background: bronchiolitis. Assessment: 62 breaths per minute with retractions. And recommendation: urgent review and potential escalation of support. Remaining calm is essential, as my demeanor helps keep the toddler and their parents as composed as possible during the intervention.
Pediatric patients can compensate for a long time before suddenly crashing. What early, subtle signs of pediatric sepsis or septic shock would trigger you to call a rapid response or huddle before vital signs completely fail?
In pediatric nursing, I rely on the principle that by the time hypotension appears, the child is already in the late stages of decompensated shock. To prevent a crash, I watch for subtle, early physiological shifts that act as precursors to instability. The first sign I monitor is an unexplained increase in heart rate that persists even when the child is calm or afebrile. If I observe a persistent, subtle tachypnea that exceeds the age-specific baseline, coupled with a change in the child's perfusion color, I become concerned. I look closely at the skin. Early indicators include mottled extremities or a capillary refill time that is sluggish, even if the heart rate remains stable. More importantly, I watch for changes in mental status. A child who is usually interactive but suddenly becomes fussy, inconsolable, or conversely, unusually lethargic and disinterested in their surroundings is a massive red flag. I also check for a decrease in urine output or a change in the character of the child's cry. If I notice a combination of these clinical soft signs, tachycardia, mild tachypnea, and behavioral changes, I initiate a huddle with the bedside doctor immediately. I prefer to be overly cautious. Acting on these subtle trends allows us to intervene with early fluids and diagnostics before the child reaches cardiovascular collapse.
A 6-year-old patient with a history of epilepsy begins having a generalized tonic-clonic seizure in their hospital bed. Walk us through your actions during the first 3 minutes of the active event.
My absolute priority is to ensure the patient's immediate physical safety. As soon as the seizure begins, I look at my watch to time the event, as the 3-minute mark is critical for determining medication intervention. I immediately clear the immediate area of any hard objects or equipment that could cause injury, and I gently assist the child to a side-lying position to maintain an open airway and prevent aspiration. I place a soft pillow or folded blanket under their head for protection, but I am very careful never to restrain their movements or place anything in their mouth. Once the patient is safe, I stay at the bedside to monitor their breathing and airway patency. I call for assistance using the room's call button to ensure a second nurse and the rapid response team are alerted. I initiate pulse oximetry and apply supplemental oxygen if I note any signs of desaturation. I keep my focus on the clock and the patient's physical response, documenting the progression of the seizure. If the seizure continues beyond 3 minutes, I ensure the rescue medication, typically a benzodiazepine, is drawn up and ready to be administered per our hospital's standing order. My calm presence is essential, as I also need to provide brief, clear reassurance to the parents, keeping them informed of what I am doing while maintaining a focused, safe environment for the child.
You need to place a peripheral 4 on an highly anxious, uncooperative 7-year-old child. What behavioral distraction techniques, topical anesthetics, or child life strategies would you deploy?
Placement of a peripheral 4 in an anxious 7-year-old requires a balance of clinical precision and psychological support. Before entering the room, I ensure all supplies are prepared outside of the child's site to reduce anticipation anxiety. I always apply a topical anesthetic, such as EMLA or a similar lidocaine-based cream, at least 30 minutes prior to the procedure. I explain this to the child as magic cream that makes the skin take a nap so they won't feel the pinch. My strategy focuses on shifting the child's internal locus of control. I invite them to choose the site, left hand or right hand, which empowers them and increases cooperation. During the attempt, I utilize a child life specialist or a caregiver to engage the child in active distraction. This could involve virtual reality headsets, deep breathing exercises like blowing out a candle, or asking them to describe a favorite movie in great detail while I work. I use simple, non-threatening language, avoiding words like stick or hurt, and instead frame the four as a tiny straw that will help them get better faster. By keeping the procedure quick, validating their feelings of fear, and rewarding their bravery with a sticker or a small prize, I turn a high-stress event into a manageable clinical task, ensuring the child feels supported rather than overwhelmed.
You are monitoring a 10-year-old post-tonsillectomy patient. What specific, frequent assessment findings would alert you to early post-operative bleeding, and what immediate actions would you take?
Post-tonsillectomy monitoring requires extreme vigilance, as the risk of secondary hemorrhage is a life-threatening emergency. The most reliable early warning sign is frequent, subtle swallowing. If I observe the child swallowing repeatedly, especially while sleeping, I immediately assess the back of the throat with a penlight to look for fresh, bright red blood. Other critical indicators include sudden tachycardia, restlessness, or a change in the color or consistency of the patient's saliva. I also monitor for signs of hypovolemia, such as pallor or a rapid pulse, even before significant hypotension develops. If I suspect bleeding, my actions are immediate and decisive. I first place the child in a side-lying position to prevent aspiration of blood. I maintain the child in a calm, upright position if they are conscious, as this can help reduce venous pressure in the head and neck. I immediately call for the surgical team and the pediatric emergency response team to the bedside. I establish rapid for access if it is not already available and prepare to administer fluid boluses as needed for resuscitation. I never leave the bedside, as a hemorrhaging tonsillectomy site can lead to rapid airway compromise. My priority is to keep the airway patent, monitor vital signs every few minutes, and prepare for a potential return to the operating room for surgical intervention.
You encounter a highly stressed, aggressive parent who is loudly complaining that their child's medication is late and threatening to leave against medical advice, AMA. How do you handle this?
When faced with a parent threatening to leave against medical advice, AMA, my priority is to de-escalate the situation while ensuring the child's safety. I first move the interaction to a private space to remove the audience, which often helps the parent feel less pressured to perform their frustration. I maintain a calm, non-defensive posture and use active listening, allowing the parent to finish speaking without interruption to ensure they feel heard and respected. Once they have expressed their frustration, I validate their feelings by acknowledging how stressful it is to see their child in pain and waiting for relief. I explain the reason for the delay honestly, without making excuses, and provide a clear, updated timeline for when they can expect the medication. If the delay involves an order issue or pharmacy transit, I inform them that I am personally advocating for its arrival. Regarding the threat to leave, I calmly explain the clinical risks of discontinuing treatment, framing it entirely around the child's health rather than hospital policy. I ask what specific concerns are driving their decision and address those directly. By keeping the focus on our shared goal, the child's recovery, I can often bridge the gap. If they still insist on leaving, I ensure they understand the medical implications, document the conversation thoroughly, and involve the charge nurse or physician to ensure the safety of the transition.
How would you explain an upcoming surgical procedure, like an appendectomy, to an 8-year-old child versus explaining the clinical scope to their parents?
When explaining an appendectomy, I tailor my communication to the child's cognitive developmental stage while remaining transparent with the parents. For an 8-year-old, I use the concrete operational approach. I avoid medical jargon and focus on what they will see, feel, and hear. I might explain that their appendix, a tiny, finger-shaped pouch in their tummy, is angry or sick and needs a doctor to take it out so they can stop feeling hurt. I use visual aids, like a simple drawing of the tummy, to show that the doctor will make a small, sleepy time magic button, incision, to fix it. I emphasize that they will be given special medicine to fall into a deep sleep, so they won't feel anything during the fix, and that I will be right there with them when they wake up. This empowers the child by making the unknown feel manageable and safe. Conversely, I explain the clinical scope to the parents with medical precision. I outline the diagnosis of appendicitis, the surgical plan, and the expected post-operative course. I cover the risks, such as infection or anesthesia effects, and explain the recovery timeline, including pain management, activity restrictions, and signs of potential complications. By providing both the empathetic, child-friendly narrative and the technical medical plan, I ensure the child feels secure and the parents feel informed and confident in the care team.
When caring for an adolescent with a newly diagnosed chronic illness, such as type 1 diabetes, how do you balance involving the parents while empowering the teen to take control of their own care plan?
Empowering an adolescent with a new chronic diagnosis requires a delicate shift from parental management to teen-led autonomy. My strategy is to view the parents as vital support systems while treating the adolescent as the primary partner in their care. During education sessions, I address the teenager directly, asking them what they already know and what they want to prioritize first, rather than speaking over them to the parents. For a teen with type 1 diabetes, this might mean teaching them how to use their glucose monitor or calculate insulin ratios, framing these skills as tools for their personal independence rather than just clinical tasks. To balance this, I schedule separate teen-only times during the day. This provides a private space for them to express fears or ask questions they might be embarrassed to voice in front of parents, such as concerns about social situations or body image. Simultaneously, I hold family meetings where we collaboratively set goals for the week. I encourage parents to adopt the coaching role, offering oversight and emotional support, while allowing the team to perform the daily technical tasks. By slowly handing over the reins of their care in a safe, monitored environment, I help them build the self-efficacy needed to manage their condition successfully outside the hospital, ensuring they feel empowered rather than defined by their illness.
Describe how you would approach a situation where a family's cultural or religious traditions directly conflict with a non-emergency pediatric care plan or dietary standard on the unit.
When cultural or religious traditions conflict with standard care, I prioritize a collaborative approach that values the family's beliefs while maintaining safety. My first step is to seek a private, neutral space to listen to the family's perspective without judgment. I use open-ended questions to understand the significance of the tradition, which helps me identify the core value they are trying to protect. By demonstrating genuine respect for their culture, I build the trust necessary to find a middle ground that respects their wishes while meeting the clinical requirements. For example, if a dietary standard conflicts with a religious fast, I consult with the hospital's dietitian and the attending physician to see if medication timing or meal composition can be adjusted to align with the family's practice without compromising the treatment plan. If the conflict involves an intervention, I look for alternatives that provide equivalent clinical outcomes while adhering to their cultural protocols. I also involve hospital chaplaincy or cultural liaisons who are specifically trained to mediate these sensitive discussions. My focus is always on creating a bridge between evidence-based medicine and the family's world. By being flexible where possible and transparent about the medical non-negotiables, I ensure the family feels empowered and respected, which ultimately leads to better adherence and patient outcomes.
Pediatric nursing delivers immense emotional highs and lows, particularly in end-of-life or palliative care scenarios. What boundaries and self-care strategies do you use to maintain your emotional resilience?
Pediatric palliative care is undoubtedly the most challenging aspect of our profession, and I believe that maintaining emotional resilience is not a sign of detachment, but a necessity for sustainable practice. My approach to self-care is rooted in the recognition that I must be healthy to provide the highest quality of care to my patients and their families. I find that creating clear, healthy professional boundaries is essential. When I am at the bedside, I am fully present, offering compassionate care to the child and support to their family. However, once my shift concludes, I engage in a deliberate debriefing ritual, whether it is talking through the day's events with a trusted colleague or simply taking a moment of silence to acknowledge the difficulty of the situation. This mental transition allows me to leave the heavy emotional weight at the hospital door, ensuring I do not inadvertently carry it into my personal life. Outside of work, I prioritize activities that restore my sense of balance, such as regular physical exercise and dedicating time to personal hobbies that are entirely unrelated to healthcare. I also actively seek out unit-based support, such as debriefing sessions following critical events, which helps our team process grief collectively. By embracing a culture of mutual support and prioritizing my own mental health, I remain a stable, compassionate, and effective advocate for my patients, even in the most difficult moments.
During a head-to-toe assessment of a 3-year-old brought in for a minor fall, you notice unusual, pattern bruising on the back and thighs that does not match the caregiver's story. What are your immediate legal and clinical steps?
My immediate clinical priority is to ensure the child is medically stable while maintaining a calm, non-confrontational demeanor to avoid compromising the safety of the patient or the clinical team. I document the size, location, color, and specific pattern of the bruising with meticulous detail, including clear, objective descriptions such as linear or loop-shaped. I perform a complete physical assessment, looking for any other signs of injury, and I obtain a thorough history from the caregiver, carefully recording their exact account of the incident in the medical record. Legally, I recognize that I am a mandatory reporter. My clinical duty is to report the suspected abuse to the appropriate authorities immediately. I notify the attending physician and the social work department to initiate the institutional protocol for suspected non-accidental trauma. It is critical that I do not confront the caregiver or disclose my suspicion to them, as this could lead to the immediate removal of the child from the hospital or escalate a dangerous situation. I focus on providing compassionate care to the child, ensuring they are protected within the hospital environment until the multidisciplinary team and child protective services can intervene. My role is to be the child's advocate, ensuring that the necessary legal and protective investigations are conducted thoroughly and appropriately.
How would you navigate an ethical dilemma where a guardian refuses a life-saving blood transfusion or critical therapy for their minor child based on personal or religious convictions?
Navigating a situation where a guardian refuses life-saving treatment for a child is one of the most complex ethical challenges in pediatrics. My primary duty is to advocate for the child's right to life and health, while still treating the family with professional empathy and respect. I begin by ensuring I fully understand the guardian's objections. I facilitate a meeting involving the attending physician, a hospital ethicist, and, if applicable, a spiritual advisor or chaplain to address the family's concerns in a safe, supported environment. During this discussion, I present the clinical necessity of the blood transfusion, clearly explaining the consequences of withholding the therapy in simple, non-judgmental language. I use the what-if framework to ensure they understand that the child's condition is critical and that the transfusion is the only viable path to saving their life. If the guardian continues to refuse, I remain at the bedside to provide comfort to the child and support to the family, acknowledging the immense pressure they are under. Legally, if the refusal puts the child's life at immediate risk, I support the medical team as they seek an emergency court order or hospital legal intervention to authorize the treatment. My role throughout this process is to ensure that while we pursue the legal necessity of the procedure, we continue to build a bridge of trust with the parents, ensuring they remain involved in the child's ongoing care. This approach prioritizes the child's survival while maintaining the integrity of the therapeutic relationship with the family.
A 15-year-old patient privately asks you questions about reproductive health or mental health resources and explicitly begs you not to tell their parents. How do you respond within legal and institutional guidelines?
When an adolescent shares sensitive concerns, my priority is to balance their need for trust with the clinical and legal boundaries of my role. I immediately explain the limits of confidentiality in a way that respects their autonomy. I tell them, I want to support you, and I value the trust you are placing in me. However, I am legally and ethically required to keep your parents informed about your care, unless there is a specific legal exception or a situation involving immediate safety risks. I never promise absolute secrecy, as this could jeopardize the professional relationship if I am eventually forced to disclose information. If they ask about reproductive health or mental health, I provide them with the information or resources they need within the scope of my practice, while encouraging them to involve their parents. I might say, "It sounds like you are carrying a heavy burden. Would you be willing to let me help you start a conversation with your parents? Or is there a trusted adult you might feel more comfortable talking to first?" If the teen is at risk of self-harm or abuse, I must follow the mandatory reporting guidelines immediately, but I do so with as much transparency as possible by informing the teen that I am obligated to keep them safe. By being honest about the boundaries of our conversation from the start, I maintain my integrity as a nurse while still serving as a helpful, supportive resource for the adolescent.
Describe a scenario where you believe a provider's discharge order or treatment plan is premature or unsafe for a pediatric patient. How do you advocate for that child if the provider dismisses your initial concerns?
I once cared for a 4-year-old patient who had been admitted for dehydration following a severe gastroenteritis episode. The child had remained afebrile for 12 hours, and the provider ordered a discharge, noting that the patient was tolerating oral fluids. However, during my final assessment before the planned departure, I observed that the child's urine output was still minimal. Their skin turgor remained sluggish, and they were unusually lethargic, a change from their playful behavior earlier that morning. I immediately voiced my concerns to the provider, suggesting that the child might still be intravascularly depleted despite appearing stable on the surface. When the provider dismissed my observation as post-hospital fatigue and insisted on discharge, I did not retreat. I requested a brief huddle at the bedside to present objective data. I shared the specific intake and output trends, the physical assessment findings, and the contrast in the child's energy levels compared to their baseline. I framed my concern by stating, I am worried that if we discharge now, the child is at high risk for readmission within 24 hours due to ongoing fluid deficits. By presenting the data clinically rather than personally, I prompted the provider to reevaluate. They performed a quick bedside exam, agreed that the lethargy was concerning, and decided to delay discharge for an additional 6 hours for maintenance fluids and further observation. The child subsequently perked up, achieved adequate urine output, and was safely discharged the following day. This experience reinforced that advocating for a patient is not about challenging authority, but about utilizing my frontline observations to ensure the safest possible outcome for the child.
While parents provide legal consent for procedures, securing a child's cooperation is vital. How do you obtain developmental assent from an older child? And what do you do if a mature child strongly resists a non-emergency procedure?
I start by building rapport with the child, ensuring they feel like a partner in their care. When preparing a 10-year-old for a non-emergency procedure, I explain the necessity using age-appropriate language and visual aids. I ask them, would you be willing to help me with this today so we can make you feel better? This request for assent respects their developing autonomy. When a mature child resists, I pause to understand the barrier. Once, a 12-year-old patient firmly refused a routine dressing change for a surgical wound, citing fear of pain. I stopped the procedure to listen, validating their feelings rather than rushing them. The task was to complete the care without causing trauma. I negotiated a compromise. We practiced a deep breathing technique together, and I offered them control by allowing them to signal when they were ready for the next step. By empowering the child to manage their own pace, the resistance vanished. As a result, We completed the dressing change calmly and successfully. If a child continues to refuse, I engage the child life team to facilitate further support, ensuring they never feel coerced while maintaining their medical safety.